Yes, I am. So this is my last presentation to the region. I hope you will allow me a little indulgence to have some fun and tell you a story of implementing an EPR system. Next slide, please, Francis. So we had to go on a quest to modernise and reduce paper in the trust, as we all have. And it is the way forward. EPR is definitely the way forward for better healthcare, but it's got to be fit for purpose. And unfortunately, my particular trust was starting on a back foot because we were truly well known for being in the dark ages where IT was concerned. So we knew it was going to be a long journey. Next slide, please, Francis. So to start with, it was all great. They said the transfusion module will have to be written for you. What do you want? We got very excited. We said, can we have consent and written information as a standard question when it's prescribed to go with NICE guidance? Can we have the reason for transfusion as a compulsory field, not just low HB, and we, reflecting the MBTC codes? Can we have flags for hemoglobin results? All those sort of things. And we were promised as well that all the necessary hardware would be provided, particularly for sample labels, because there was a push to have sticky labels for all sampling. Next slide, please, Francis. So we gave them the shopping list. Agreements were made, but unfortunately, after that, there was a lot of silence. Communication sort of broke down. There were no more meetings. Admittedly, this was in the middle of the pandemic, but the trust made a decision to push through, so we did. Next slide, please, Francis. And lovely. So we felt like our fellowship had been disbanded. No communication from the company. I will not mention the company's name. No communication from the trust either. Our actual contacts that we had vanished, and there was no product to test, and the go live date was approaching. Next slide, please. Francis, could you just go through? That's brilliant, thank you. So we were getting closer and closer. I mean, obviously, as all go live dates go, it did keep moving. It was it kept getting pushed back. But even so, there was very little meaningful training from the trust. We as a TP team hadn't tested the module, hadn't even had eyes on it. We didn't even realise that there were going to be different views for different users. So we didn't even have an idea of who could see what. They did a full dress rehearsal. That's what FDR means. And this was only a couple of weeks before go live. By chance that for the bedside checklist, they'd missed out checking the expiry date, and actually I have to thank MHRA for getting that fixed before go live, because we'd actually had a couple of reports where blood had been collected and it had been expired. So I managed to use the MHRA BAT and tell them that it had to be fixed. But even so, we really didn't have any idea what was going on. So next slide, please, Francis. Thank you. So we went go live. We went on over a whole weekend. The whole hospital and the partnership trust there were two trusts doing the same thing with the same product. And the whole thing went live over one weekend. What did we discover then? Well, the unit numbers didn't scan into the system. Observations on the task list. So we'd deliberately set up all the obs to go to be requested. They didn't appear in order. So if you didn't check, you could do your end obs as your baseline obs. The ending of the transfusion was a separate task. It got missed, and the bedside checklist wasn't mandatory, so often that got missed. I did suddenly realise on the Monday that there was no paperwork left to collect blood with, because we had a pathway that was used for collection, and because we don't have blood track, I told you we were in the dark ages around IT, suddenly realised there was nothing to go and collect blood with, but I sorted that out. There certainly wasn't enough label printers as we had been promised, and our trust had no wrong blood in tubes in the previous year, and since go live in the middle of May we've had 7 to date, so you can see that there are issues. Next please, Francis. So where are we now, sort of today? Well, my colleague and I are putting together some proper training package with hopefully a video, so that people can watch and know how to prescribe, administer and collect, etc. We're auditing to look where the problems lie. The TP team, we just can't rectify all these issues on our own, so we're sort of logging things on the appropriate platforms, so that we can identify trends and get the trust involved. I mean, it is so much bigger than transfusion. The whole thing is a bit of a mess, to be fair, but I'm just concentrating on the transfusion side of it. Next, please, Francis. So there are some good things about the UPR. I didn't want to be all doom and gloom for this. Traceability, if the unit number was entered manually into the system, because I said the barcode reader didn't really work properly, it's been a revelation for me, just literally sitting at my desk finding units that have been transfused if the tag hasn't been returned. So I find that really good. Auditing, it will be simple once we have an audit program written that will pull the required data. A little thing here to say, if anybody is implementing EPR, get them to write those programs up front, otherwise it takes a long time to get them to do them after you've gone live. But I'm quite happy to sit and pull the data for audit off one system, not having to file through, well, not having to find the notes to start with, and then trying to find what you need in the midst of bits of paper that are not even filed in the correct order. So, as I said before, the compulsory fields for consent, written information and reason for transfusion, they're brilliant, the fact that they're there. I've also found that obviously the system can't prescribe blood over sort of 4 or 6 hours, as I've seen previously when it's been written. They can only prescribe it over 10 minutes, 30 minutes, 1, 2 or 3 hours. So there's no issue of blood being up and infused to the patient longer than the 4 hours out the fridge. Next, please, Francis. So we know it's going to take a long time to get there and back again. Colleagues that we talk to at other trusts using the same system still say they have issues 5 years down the line, so we're not hopeful. But I'm sure it will get better. So thank you for coming on this unexpected journey with me, and I shall see you all at some point.